Welcome back to Doodle Nurse. In part one of this series, we are going to talk about penicillins, a major group of antibiotics known as drugs that weaken the bacterial cell wall. Penicillins belong to the beta-lactam antibiotic family. They are low in toxicity for humans and are bactericidal, meaning they actively kill bacteria rather than just stopping growth. Penicillins work by targeting the bacterial cell wall, which is essential for bacterial survival. By weakening this wall, bacteria becomes unstable, they swell, and eventually burst, leading to cell death. You'll also notice that some penicillins are combined with medications like sulbactam or clovelanate. These drugs help protect penicillins from bacterial enzymes that would otherwise inactivate them. We'll explore that in more detail later in this series. This video is designed to give you a strong foundation so that everything that follows, mechanism of action, resistance, and drug classes makes sense. And just a quick reminder, this content is for educational and informational purposes only and is not a substitute for medical or professional advice. Let's start with the big picture. Penicillins are bactericidal antibiotics, as mentioned earlier, meaning they kill the bacteria rather than just inhibiting growth. They'll have low toxicity to humans because we do not have the cell walls. One key concept to remember is that penicillins work best when bacteria are actively dividing. So if bacteria are dormant, penicillins are much less effective. Penicillins interfere directly with bacterial cell wall synthesis. They inhibit an enzyme called transpeptidase, which is responsible for cross-linking peptidoglycan strands. Without these cross-links, the cell wall becomes weak and unstable. Penicillins also activate the autolysins, which is an enzyme that breaks down the existing cell wall. So as water enters the weakened cell, the bacteria swells, ruptures, and dies. This is why penicillins are considered bactericidal. The molecular targets of penicillins are called penicillin-binding proteins or PBPs. PBPs are located on the bacterial cell membrane and they play a critical role in building and maintaining the cell wall. Penicillins must bind to these PBPs in order to work. If PBPs are altered or mutated, penicillin cannot bind effectively, leading to drug resistance, which is a concept that becomes especially important when we discuss MRSA, MRSA, or the methicillin resistant Staphylococcus aureus. The gram-positive bacteria has a thick peptidoglycan layer and has no outer membrane. This allows penicillins to easily reach their target PBPs. As a result, penicillins are generally very effective against the gram-positive organisms. This explains why early penicillins were primarily used to treat gram-positive infections such as MRSA. Gram-negative bacteria have a more complex cell envelope. They contain a thin cell wall and an outer membrane and porine channels. Penicillins must pass through these porins to reach PBPs. This additional barrier limits drug entry and explains why many penicillins are less effective against gram-negative organisms unless they are specifically modified. Bacteria can become resistant to penicillins in three major ways. First, by producing beta-lactamase enzymes, which destroys the beta-lactam ring. Second, by altering PBPs, preventing drug binding. Third would be by decreasing drug entry through the outer membrane. So when penicillin therapy fails, always consider antibiotic resistance. Beta-lactamase is also called penicillinase. This is an enzyme that breaks the bacteria beta-lactam ring, rendering penicillin inactive. Many bacteria carry these beta-lactamase genes on plasmids, which can be transferred between organisms. This is one of the reasons resistance can spread rapidly in healthcare settings. Now let's talk about the big guy, MRSA or MRSA. It stands for methicillin-resistant Staphylococcus aureus. MRSA does not rely on beta-lactamase for resistance. Instead, it develops resistance through the altered PBPs, which prevent beta-lactam antibiotics from binding. MRSA is resistant to penicillins and cephalosporins. Treatment options include vancomycin, daptomycin, linezolid, and ceftaroline, which is the only beta-lactam effective against MRSA. Penicillins are divided into four main classes: the natural penicillins, penicillinase-resistant penicillins, aminopenicillins, and extended spectrum penicillins. Knowing this class will help predict spectrum of activity, resistance patterns, and clinical use. Narrow spectrum penicillins target fewer organisms and are more precise, while broad spectrum penicillins cover a wider range of bacteria but increases the risk of superinfections and antibiotic resistance. So, whenever possible, clinicians aim to use the narrowest effective antibiotic. Beta lactamase inhibitors protect penicillins from enzymatic destruction. Common combinations include amoxicillin clavulanate, ampicillin sulbactam, and piperacillin tazobactam, commonly known as the Zosyn. These inhibitors do not kill bacteria on their own, so they simply protect the penicillin and expanding coverage. Penicillin allergy is the most common medication allergy. Reaction range from mild rashes to life-threatening anaphylaxis. Always clarify the type of reaction a patient experienced. For patients with true penicillin allergy, penicillin should be avoided and caution should be used with cephalosporins. Nurses must monitor patients closely after administration and especially after the first dose. Penicillins may be administered orally, intramuscularly, or intravenously. They distribute well into most tissues and body fluids, so penetration into the cerebrospinal fluid improves when the meninges are inflamed. Penicillins are primarily eliminated by the kidneys, so making dosage adjustment critical in patients with renal impairment. Common side effects include nausea and diarrhea. Penicillins are most common cause of Clostridium difficile or C. diff associated diarrhea, especially with the broad spectrum agents. Serious toxicities include anaphylaxis, neurotoxicity at high doses, kidney injury, and very rare liver enzyme elevations. Therefore, monitoring renal function is very essential. Penicillins are widely used across the lifespan. They are generally safe in infants, pregnancy, and breastfeeding. Older adults, though, are at increased risk of toxicity due to declining renal function. Individualized dosing and close monitoring improve safety. Just a quick recap: Penicillins are bactericidal beta-lactam antibiotics that target PBPs and weaken the bacterial cell wall. Resistance occurs through beta-lactamase production, altered PBPs, or reduced drug entry. MRSA requires a non-beta-lactam therapy. Always assess allergy history and renal function before administration. And when it comes to antibiotics, safety, specificity, and stewardship matter. Once again, this video is for educational and informational purposes only. It does not replace medical professional advice. If this video helps, please like, share, and subscribe. Thanks.